Secure the chest tube to the skin using the heavy sutures. Simple interrupted or mattress sutures are often satisfactory to ensure stability of the tube and avoidance of air leaks around the tube. The free ends of the sutures are wrapped around the tube and tied multiple times to secure it in place. Purse string sutures are not recommended as they yield poor cosmetic results and increase the risk of skin necrosis. Once the chest tube has been secured, a petroleum-based gauze dressing should be wrapped around it. Apply several pieces of sterile gauze around the tube. Secure the site with multiple pressure dressings. A chest X-ray must be done to confirm correct placement. On an X-ray, the radio-opaque stripe is visible with an interruption indicating the position of the proximal hole. This hole must be within the pleural space. Otherwise, it is sitting outside the pleura and not draining effectively. This is an indication to replace the tube altogether. Do not advance the tube into the chest, as this can introduce non-sterile tubing into the chest cavity. Before unclamping the free end of the chest tube, firmly connect it to the sterile drainage system. Now unclamp the free end. If pleural fluid is being drained, the fluid level in the drainage system will rise. If a pneumothorax is being evacuated, air bubbles will appear. Do not reclamp the chest tube while there is bubbling. This may lead to recollection of a pneumothorax and may even result in a tension pneumothorax. Most commercially available drainage systems use the 3-bottle model of closed drainage and suction. The most important bottle is the underwater seal, which serves as a one-way valve that allows air and fluid to leave the pleural cavity without the risk of re-entry during inspiration. All available pleural drainage systems contain the underwater seal bottle. Bubbling may be seen in this bottle. This will indicate whether there is an ongoing air leak either from the patient or from the system itself. The 2 other bottles that may be present in the drainage system are a collection bottle connected directly to the patient for accumulation of pleural fluid and/or debris, and a suction system that connects to wall suction but regulates the amount of suction actually delivered to the pleural space via a column of sterile water. Suction may be applied if there is a persistent pneumothorax despite the underwater seal, or if a viscous pleural collection is not draining effectively. When evacuating chronic large pleural effusions, the risk of re-expansion pulmonary edema has been well described. A stepwise approach to the drainage of chronic large pleural effusions is recommended, not exceeding 1 to 1.5 liters within a 30-minute period. The pleural drainage system must be kept approximately 40 inches below the patient in order to prevent retrograde flow of air or fluid back into the pleural space. There are complications associated with the insertion of a chest tube. These include bleeding and hemothorax, traumatic perforation of the lung, heart chambers, diaphragm, or intra-abdominal organs, intercostal neuralgia due to trauma of the intercostal neurovascular bundle, intermittent blocking of the tube with clot or debris, subcutaneous emphysema, re-expansion pulmonary edema due to more than 1 to 1.5 liters of fluid drainage in less than 30 minutes, infection of the drain site, and empyema. The timing of chest tube removal depends on the indications for the chest tube. In the case of a pneumothorax, bubbling must have ceased, the patient stabilized clinically, and the lung re-expanded on a chest X-ray as minimal criteria to remove the tube. If suction is being applied to evacuate the pneumothorax, most clinicians perform a trial of underwater seal alone in order to ensure there is no further bubbling with the suction turned off. Most physicians will perform a chest X-ray 12 to 24 hours after the last evidence of an air leak prior to removing the tube. If the chest tube was placed to drain pleural fluid, once the drainage volume is less than 200 cc's in a 24-hour period and the fluid is serous, the tube may be removed. If a chest tube was placed for empyema, removal of the tube should be considered only after the patient has stabilized clinically and the drainage criteria are met. If an air leak is persistent, or the pleural fluid drainage criteria are not met, a pulmonary specialist or thoracic surgeon should be consulted for more definitive, potentially surgical management. Pneumo moved, instruct an awake patient to hold his or her breath either after a full inspiration or full expiration, or while performing a Valsalva maneuver. Pull the tube at end expiration if a patient is being mechanically ventilated. Ideally, 2 clinicians should be present during tube removal. Once the tube is removed, quickly seal the incision site with a petroleum-based gauze, reinforced with several pieces of regular gauze on top of it. Secure the site with a pressure dressing. Additional sutures may be required to close the incision. A follow-up chest X-ray should be obtained 12 to 24 hours after the tube has been removed. Closely inspect for any suggestion of a new pneumothorax. Caution must be exercised when removing a chest tube from any patient on a mechanical ventilator, especially in those with high oxygen or positive pressure requirements, chronic lung disease, or other risks for recurrent pneumothorax.